is that one not working?
Both of them work. And whenever you're ready, you can just flip the switch and you'll be unmuted.
Oh, okay. And what was I going to say? Is there, this is a pointer?
Yes.
Okay. All right, you tell me when to start because I can't see the clock. Not yet? 2 minutes? Okay. Good morning, guys. Good morning. We're going to get started. I am Cynthia Janfi-Bannerman, or Cynthia Janfi. I'm a professor in the Department of OBGYN and in the Division of Maternal Fetal Medicine. And welcome to your pregnancy lecture. So even 20 years ago when I was a first-year medical student, there was one lecture in all of the kind of first part of medical school about pregnancy, so this is it. I know you have some other folks from the REI department or division. We have a few subspecialties within OBGYN, maternal fetal medicine being one of them, reproductive endocrinology, family planning. I know that some of them are speaking to you during this module. So we'll go ahead and start this talk. And can you guys hear me if I step away from that microphone? Not really. Let's see. All right, is this better? Yep, okay, perfect. If you can't hear me, just wave, and I'm kind of short, so if you can't see me, sorry. Alrighty, so dispelling the myths and understanding the changes that led to each of us. For some of you who are from non-medical families, the day you walked into medical school became the day you became an expert. So these are some of the things that your family members might ask you about pregnancy. All right, conflicts of interest. So I am on the advisory board for Smith & Nephew. Smith & Nephew is a wound company. Clearly has nothing to do with this talk. All right, so how long is a normal human pregnancy? Ideas? Okay, hopefully by the end of this, you guys will say that that's not quite right. Pick one. 40 weeks. Excellent. So pregnancy dating is actually incredibly important. You will move away from your lay response of 9 months, and as you become a doctor, you'll move towards your 40 weeks response because we don't use months at all in obstetrics. So the answer is 40 weeks of gestation. So 280 days is what the length of gestation is considered for a pregnant human, different for different species. Dating is always going to be based off of the last menstrual period, and it assumes that everyone ovulates on day 14, which is why obviously that's not going to be the case, and people get redated plenty of times, but these were kind of the paradigms that created pregnancy dating. The due date, which is either EDD, or EDC, confinement back in the early 1900s, is 40 weeks. It's important that you know that only 5% of babies actually come on the due date. So we don't give you a due date because we think your baby's going to come that day. Dating a pregnancy is for intervention and not so much for prediction of when the baby will arrive. It used to be that we used Nagel's rule to date a pregnancy. So if you know when your last menstrual period was, you subtract 3 months from that, add 7 days, and that's how you date the pregnancy. And it still works, and you can still use that, but in the kind of electronic area, we use an app. Much easier. Alrighty, like I said, only about 5% of pregnancies are actually going to deliver on their due date. Again, the due date is not when we think that the baby's going to come, and I feel like I explain that every week when I'm seeing patients. So dating a pregnancy, we use menstrual weeks. We still use menstrual weeks. It'll always be menstrual weeks. Even if we know exactly when you conceive via IVF, we still use menstrual weeks, so that not everyone is going to have a 2-week difference based off of if we're using conception weeks versus menstrual weeks. By physical exam, we can date a pregnancy. So a uterus, a normal uterus, non-fibroid uterus, should reach the umbilicus by 20 weeks gestation. And actually, it goes up and down a centimeter from 20 weeks to equal the gestational age. So this is what we used to do pre-ultrasound. You could just palpate a woman's abdomen. If it's 8 centimeters above the umbilicus, she's 28 weeks. And that still works today. We actually measure fundal heights and can figure out pregnancy dating that way. Of course, we have ultrasound these days, but that's another way to correlate it. Quickening is another thing, again, from the 50s and 60s. You generally first perceive fetal movement around 19, 20 weeks. And if you had no other information on a woman with her first pregnancy and she felt fetal movement, you could guesstimate that that's maybe where she was. Alrighty, so dating a pregnancy, detection of fetal heart rate. So there are actually a couple of more legitimate ways to date a pregnancy. If you're able to detect a fetal heart rate by Doppler, then generally that's about 11 to 12 weeks, and this is a Doppler. This is a fetoscope, and of course it's for historic perspective. Clearly we don't use this anymore, but that's what they used to use, placed on the person's head similar to this, and then you could detect a heart rate as early as 19 or 20 weeks. Ultrasound. So of course this is what we're using now. It's more accurate earlier in the pregnancy. So if your first scan is at 36 weeks, we are not going to know exactly how far you are. It's going to be plus or minus 3 weeks. What we do is we will ask the woman what her last period is, and then if it correlates with the ultrasound more or less by plus or minus 1 week, plus or minus 2 weeks in the second trimester, or plus or minus 3 weeks in the third trimester, then we will say that your last menstrual period is accurate, and we're going to use that for your dates. If it's outside of that window, then we actually use the ultrasound dating. That's the convention today in 2015. There are centers who are completely ignoring last menstrual period dating and kind of moving towards ultrasound dating, but this is how we date a pregnancy. Trimesters. So you've probably heard 3 trimesters. When do they start? When do they stop? Nobody agrees. It's a gestalt. So the first trimester is from week 1 to about 14 weeks. Some folks use 12. Second trimester, again, somewhere in the beginning around 12 to 14 weeks, and about 24 to 28 weeks in that range. And then third trimester, about, again, 28 weeks to delivery or earlier. Nobody really agrees, and it's really not necessarily that important. But importantly, pregnancies are going to be dated by menstrual weeks. So even if we use the ultrasound, it'll change it into menstrual weeks, and that's what it will be moving forward. Alrighty, so pregnancy terminology. When you come to the obstetric unit, you're going to hear us say, this is a blank-year-old, 22-year-old, or in our units, 42-year-old. Gravida X para XXXX. So what does this mean to us? Gravida is the total number of pregnancies you've had in your life. And parity, so these 4 blanks, is going to be full-term, preterm abortions, or living. And growing up in Florida, it made it very easy to teach this. FPNL is our system for electricity, Florida Power and Light. So full-term, preterm, abortions, living. However you remember it, that's what the 4 blocks are for parity. So a first pregnancy, if someone came in for their first pregnancy, you would say she's a 42-year-old G1P0, gravida 1 para 0. First pregnancy. However, if it's the 4th pregnancy and the patient has had 1 miscarriage, she's had 1 term delivery, 1 term demise and 1 term living, can you guys guess what her parity would be? She's a G4, good, and a P. Work with me, guys. Alrighty, I'll give it to you. 2011. So this is her 4th pregnancy. She had 1 term demise, so there's no child here for the living children. 1 term living, so this is the 2nd term pregnancy that was living, and then the miscarriage, which counts as a spontaneous abortion, right in this category. So that's how that works. And this is our kind of vernacular, and every sentence that presents a pregnant or non-pregnant woman, because they don't necessarily need to have a G, will start with that parity, and that's how we do our histories. All right, so why is dating so important? I'm kind of going on and on about pregnancy dating. So here's a first clinical correlate. So you have a 32-year-old G1P0. She comes at 24 weeks gestation, comes in for her first ultrasound. and you diagnose anencephaly. So there's only partial cranium, there's no brain, this baby is not going to live after birth. But you can't offer her a termination because you determined that she's 24 weeks and 0 days. If she were 23 weeks and 6 days, so if she presented the day before, you could offer her legally a pregnancy termination. This is why pregnancy dating is so important in our field, not because nothing to do with predicting when the baby's going to come, but what interventions can we do for certain clinical scenarios. Similarly, here's another scenario. So a 41-year-old G3P1011, she's at 36 and 5-7 weeks, and she has mild preeclampsia. So you would admit her for observation in that scenario. However, if she would have been 37 weeks, so 2 days later with the same diagnosis, you would have delivered her. So you would have admitted her for delivery. So again, our management plans and everything that we do really changes based off of just 1 day difference. And so that's why dating in pregnancy is so important. All right, so the majority of the rest of this talk is going to focus on physiology and the physiologic changes of pregnancy. That's why they've kind of stuck us in the endocrine module. And so most things that you've learned in physiology are going to be different in a pregnant woman. Lab values are going to be different. The way they respond to things are going to be different. And so we'll kind of go through organ system and talk about all of those. So during pregnancy, almost all organ systems have some kind of anatomical or functional change, and it alters criteria for diagnosis of a disease. So while you might learn this now and learn this through the course of your medical school, if you don't go into OB, a lot of times people are slightly frightened by a pregnant woman because they just can't remember what was normal, what's abnormal, what does this mean. It starts as early as fertilization, and many of these changes will resolve after delivery, but usually by 6 weeks postpartum, which is why we schedule the postpartum visit for 6 weeks to make sure that they've gone back to their normal physiologic changes. Because of these changes, many people who have underlying diseases or subclinical diseases have those diseases unmasked during pregnancy. So you can't just be kind of healthy and then attempt a pregnancy, which we see a lot of times in our 40-plus crowd who comes in for a preconceptional consult about, well, you know, my lupus hasn't flared in 6 months. Pregnancy will definitely unmask those things. So here's the first common complaint that we get. So the hematologic system. I feel tired all the time. I'm sure you guys recognize your red blood cells. So what's normal and what needs further evaluation? So during pregnancy, your blood volume will increase. You need to increase the blood volume in order to properly perfuse the placenta and the growing uterus, which goes from essentially tiny size to 40-week gravid size. The blood volume increases, aside from just perfusing the placenta, also protects against blood loss at delivery. So on average, the average blood loss for a vaginal delivery is about 500 cc's. The average blood loss at time of cesarean is 1 liter. And so you have to build your blood volume such that you don't become severely anemic after the course of pregnancy. There's also a physiologic anemia of pregnancy such that the plasma volume will increase more than the red cell volume. So while your plasma volume is higher, red cells are lower, so you become physiologically anemic. Also, by decreasing the viscosity by your plasma volume to red cell volume ratio, you improve placental perfusion, because your whole goal is to have a low resistance space such that the placenta gets adequately perfused. So in terms of other hematologic changes, so by the 7th week, a lot of women have not realized that they're pregnant yet. By the 7th week, you'll have a 10% increase in your plasma volume. By about 32 weeks of pregnancy, that increases further to about 45 to 50%. But the red cell mass, less than the plasma volume, increases by about 32% in the 3rd trimester. So what I tell most of my pregnant patients is that you're not anemic now, you probably will be anemic by the end of this pregnancy, and so it's a good idea for you to take your prenatal vitamins and sometimes supplement iron, particularly if it's more than a singleton gestation. Pregnancy is interesting in that it's a hypercoagulable state, and that's one of the things that actually attracted me to do the high-risk pregnancies, because you have an increase in factors 7, 8, 9, 10, and 12, and you have a decrease in protein S, such that any pregnant woman becomes hypercoagulable just by the onset of pregnancy. If you, again, have an underlying reason why you are hypercoagulable, this becomes a dangerous scenario for you. The hypercoagulable state implies that you have appropriate prophylaxis against thromboembolism. So if you're operating on a pregnant woman, let's say you're a general surgeon, it doesn't have to be an obstetrician doing these types of surgeries, you need to make sure your pregnant woman has Venadines. You can consider prophylactic dosing of heparin. You want to avoid prolonged immobility. So for instance, if you're a pregnant woman and you're flying to Japan for your wedding, like a patient of mine a few years ago, she's got to walk around on that flight a couple of times because prolonged immobility could lead to a thrombus. Thrombophilias, you've probably heard of these at some point. There are several different types of thrombophilias, hereditary and acquired. The hereditary are going to be effector V Leiden mutations, prothrombin gene, protein C or S deficiencies. These occur in pregnant women similar to non-pregnant women, and because they're predisposed to being hypercoagulable at baseline, some of these women are going to need heparin prophylaxis throughout the pregnancy. Acquired would be your antiphospholipid antibody syndrome, and that's something that you may or may not have heard of yet, but that's also a hypercoagulable state, and actually some of the ways to diagnose this syndrome are related to adverse outcomes with pregnancy. Thrombophilias are associated and have been, maybe not so strongly, but in a lot of epidemiologic type studies have been associated with adverse pregnancy outcomes. There is an increased risk of pregnancy and an increased risk of fetal demise, and so we really need to identify who these women are and treat them appropriately. All right, so a clinical correlate. So you have a 22-year-old G3P0020. She's at 12 and 4/7 weeks, and she presents to the emergency room with acute shortness of breath, right? Leg swelling and palpitations. You're the emergency room resident, and you're trying to call your friend who went into OB, but they're not there yet, so what do? All right, so your suspicion is high for a PE. You remember this talk. You're like, this is a PE. I know that she's hypercoagulable. You order a spiral CT, call the OB resident, and you do a full thrombophilia workup because your spiral CT was positive, and it shows protein C deficiency. So not only is she pregnant, but she has protein C deficiency. She gets started on anticoagulation. What meds do you choose? So this is a whole other area that we're not really going to touch on in today's talk, but there are several medications that are teratogenic. So when you're treating a pregnant woman for any type disorder, you want to make sure you're using the right thing. So if you're thinking, I'm going to use warfarin or Coumadin, that actually causes embryopathy. And so you stay away from those types of medicines. In someone who's pregnant, you would rather do heparin or Lovenox, which is low molecular weight heparin. But this is a very, very common scenario. So you'll definitely see this. All right, moving along to the cardiovascular system. So your patient says, I feel like my heart is racing. Or I felt like I was about to pass out in the ultrasound suite. Because we do a lot of ultrasounds. We have pregnant women laying on their backs. Next thing you know, they become syncopal. So what's normal? What needs further evaluation? Cardiac output, heart rate times stroke volume, right? It increases during pregnancy. So in the long pregnant state, normal cardiac output's about 4 to 5. But when you're third trimester, it's up at about 6 to 7. And then in labor, it increases again by another 30%. So now think of a woman who has an intrinsic cardiac defect or some kind of hypertrophy or any cardiac lesion. They can't tolerate this like a normal pregnant woman can. So these are the things that we're constantly thinking about in terms of how do we monitor these people, how are they going to be able to tolerate the increases in stroke volume during labor. And one of the ways that we actually treat these women is by giving them an epidural, because aside from the normal effects of an epidural, what you think of epidural, you think, oh, it helps with pain. It helps with so many other things in pregnancy, and it can actually decrease your heart rate, and it can actually help for women with cardiac lesions who need to undergo a delivery. So this is just another slide looking at cardiac output in pregnancy. This is the non-pregnant state. Again, we said 4 to 5. And through the weeks of gestation, it just is always increased over the non-pregnant state. And then this is what happens in labor. And so not a lot of women with cardiac disease are not going to be able to tolerate this too well. And then postpartum, it goes even higher. And then it starts to resolve again as you get towards 2 weeks and then 6 weeks. But so this is what happens to cardiac output in pregnancy. And it's also position dependent. So in the third trimester, there's actually a 10 to 30% decrease in cardiac output if the woman turns from left lateral to supine. And this is because there's compression. So the gravid uterus, you can imagine, as it gets larger, starts to compress the inferior vena cava and reduces the venous return. The fall in cardiac output is going to be compensated by a rise in peripheral vascular resistance, such that supine hypotension is not uncommon. So we do see, if we're scanning someone who's over 20 weeks and we've been scanning them for some time, every once in a while we'll have women pass out in the ultrasound suite, and then the techs go crazy, and we give them, we sit them up, give them some alcohol, and alcohol sniffing, not alcohol to drink, and then everything is fine. But so, yeah, so this would be normal, and this is what we see. This is why we tell women who are gravid, probably more than 20 to 24 weeks, that they shouldn't sleep flat on their backs. So this slide just kind of looks at positional changes, what happens to cardiac output. The red, if you can see that, the red is supine, yellow is on the left side, and then sitting in blue. And so there are positional changes, and they change throughout weeks gestation. So in labor, again, labor is the time where everything is going to increase. So your cardiac output increases 12% at the beginning, and then about 51% above your term baseline. During a contraction is when you maximally have maximum amounts of cardiac output, and you have about 300 to 500 cc's of return going from the placenta to maternal circulation. Further, you'll have a 10 to 20% rise after delivery of the placenta. So again, huge changes in cardiac output. So what's the clinical correlate? Alrighty, so you have 19-year-old G1P0, she's at 24 weeks, and she presents to you with acute appendicitis. Okay, again, trying to make these non-obstructive, because for those of you who are lucky enough to go into the field, you'll see a lot of this, but for those of you who aren't quite as lucky, you'll still see them on your surgical rotation. So she's presenting to you with acute appendicitis, and as the OB, you recommend left lateral positioning during the surgery to maximize the cardiac output for the mom and the fetus. So the anesthesiologists, are going to be aware of this for the most part, but if you are an anesthesiologist and you're managing a case of a pregnant woman, you want to remember that once they're over 24 weeks, you want to adjust for cardiac output in these cases. Alrighty, here's another scenario that's unfortunately not too uncommon, but a 43-year-old G2P0. She's at 35 weeks and has a cardiac arrest. So the paramedics are doing CPR, and there's no response. But they don't realize that they're not getting good cardiac output because she's flat on her back. So you place a wedge on the person's back, putting her in a lateral position, and she becomes resuscitated. And so this just is a pictorial view of how to do that. You don't necessarily need any fancy wedge. This is a chair and this is a pillow. Woman's on her side. This will significantly increase her cardiac output. They have different kinds of wedges that have been made, but this is part of the basics of resuscitation of a pregnant woman who undergoes cardiac arrest. So things to keep in mind. Alrighty, I need to use the bathroom every hour. If you've ever been pregnant or know a pregnant woman, this is absolutely true. So now what's normal and what's a UTI? You can't really use urinary frequency because that's everybody. All right, so the anatomical changes. The kidneys get bigger, basically, bottom line. There's increased renal, vascular, and interstitial volume. Right side is always going to be larger than left, so if you're the radiologist that's reading the scan that we've done for the pyelonephritis, right side is going to be larger than the left. The uteral and the renal pelvises are going to dilate by 8 weeks, so there's going to be moderate hydronephrosis always. That's going to be a normal finding. There's mechanical compression of the uterus and ovarian venous plexus. Again, if you're predisposed to having a hypercoagulable state and now you have compression, then you have stasis. There's smooth muscle relaxation by progesterone, and so these are, again, all normal changes. You have increased plasma flow and increased GFR. Your non-pregnant state is going to be about, on average, about 120. During pregnancy, you go up to 150 to 200. And over 50% over your non-pregnant state by the end of the first trimester. So things are moving more quickly, and then the kidneys tend to make more mistakes, such that if you see a little bit of glucose as you're doing a dipstick in a pregnant woman, that's probably normal. Maybe not 4+, but if you see trace glucose, the kidneys are working very hard, and they can't always do things as appropriately as they would if you were not pregnant. This takes almost 3 months postpartum before it resolves. So what happens to creatinine? So because of all of these changes, normal creatinine is about 0.8, but in pregnancy it goes down. So if we see 0.8 in a pregnant woman, and you were just looking at the lab cutoff that said, 0.6 to 1 is normal, then you would miss the fact that this is abnormal in a pregnant woman. This is more than 2 standard deviations above the mean. Glycosuria, again, in a non-pregnant state, folks can spill a little bit of glucose. In a pregnant woman, you tend to spill more, again, just because your kidneys are working much harder. And then proteinuria, if you don't have pre-existing proteinuria, everybody spills protein, so there's not going to be someone who has 0. But if you don't have a large amount of proteinuria pre-existing, then there's really no change in pregnancy. If you do have pre-existing proteinuria for hypertension or diabetes or whatever comorbidity that you have, then that tends to worsen over pregnancy. Significant proteinuria in pregnancy is something that we diagnose if there's 300 cc's in a 24-hour urine collection. More recently, we've actually started using PC ratios also, but our gold standard is always going to be the 24-hour urine collection to assess protein in a pregnant woman. And this becomes important in the diagnosis of preeclampsia. So we actually do these quite frequently. So what are the clinical implications of these changes? So you have urinary stasis. Urinary stasis is kind of a state that will lead towards more urinary tract infections. You can have asymptomatic bacteriuria that can actually lead to pyelonephritis, which is the most common infection during pregnancy. And pyelonephritis can, in some cases, lead to ARDS. So these can actually be very serious in a pregnant woman. So we are very keen on and very eager to treat UTIs during pregnancy to prevent pyelonephritis and possible ARDS. So if you're working in an urgent care center and you see a pregnant woman and she has dysuria, you probably want to treat her empirically. No harm towards treatment. If you're not sure of the antibiotics, call us and we'll tell you which ones to use. But we're trying to prevent pyelonephritis, which can be very serious. Pharmacologic implications. So you've got lower plasma levels of everything you give them, so it might not work as well. That's just in general. And then obstetric, we talked about diagnosis of preeclampsia, hypertension, and proteinuria. Okay, next complaint that we get all the time. I feel short of breath. So what's normal? What's a pulmonary embolism? That's kind of our everyday question. So anatomic changes for the respiratory system. There's a configuration of the thoracic cage changes that happen early in pregnancy. There's an increase in your subcostal angle, your transverse diameter, circumference of the chest, and then with advancing gestation, what happens is that the diaphragm gets pushed up by the uterus such that you are very short of breath, and it becomes very difficult for you to speak in long sentences. I remember when I was 20 weeks pregnant, I had to give a talk of all places in Utah, and it was, not only was it altitude, but it was just terrible, and I just could not catch my breath. And then at 29 weeks, I had to give a talk in Aspen. Torture for a pregnant woman, but it was, but these things happen, and this is considered normal. So what are some of the physiologic changes? If you look over here on the right side, you'll see that the residual volume is lower, and your tidal volume is a little bit higher because you're struggling to catch air. And for most times, this is normal. If this is happening to someone very early in the first trimester, then that's probably abnormal. But one of your goals will be, let me just check your oxygen saturation and see, how can I triage you? And if it's normal, 99%, on room air, you're fine. If it's 90%, she needs an evaluation for a pulmonary embolism. In terms of more physiologic changes, so you've got an increase in your tidal volume, increase in your minute ventilation, and this is progesterone mediated. Your ERV is going to fall by 20%. Vital capacity and inspiratory reserve are unchanged. But because the diaphragm, like we talked about, is elevated, you're going to have decreases in your lung volume, decreases in your residual volume, and decreases in your functional residual capacity. So I feel short of breath. I hear it probably every time I'm in the office. 60 to 70% of patients are going to have this complaint. Generally, we'll start in the late first or early second trimester. I triage them by an O2 sat and try to figure out which ones probably have some pathology versus not. Lower extremity Dopplers. So you're going to see this as you go through your wards. Lower extremity Dopplers are close to useless in a pregnant woman because, number one, only 50% of the clots are going to be in the lower extremity. Actually, most of them are in the pelvis. So just because you didn't find one there doesn't mean that the woman doesn't have a PE. And clearly, if they're short of breath, you want to look for pulmonary symptoms. So if you're going to rule them in or rule them out, you want to do a spiral CT, not in some of these other tests. So it's likely due to a variety of factors. There's also reduced PaCO2. So that is also contributing to the shortness of breath. And there's just an awareness by the pregnant woman that the tidal volume is increased. So our goal, and everybody's goal in a pregnant woman, is to differentiate what's normal from pathologic. Never miss a pulmonary embolism. All right, moving on to the GI system. I'm constipated, I have heartburn, I can't keep anything down. Again, things that we hear all the time, what's normal and what needs further evaluation. So there's increased appetite early in the first trimester, not for everybody, and some women who don't have that feel concerned that they don't have it, and that's fine. But for a lot of women, they feel incredibly nauseous, about 60 to 70%. And so what happens is whatever their normal diet is usually replaced by some kind of carb so that they can actually not vomit or not have that nauseous feeling, and so a lot of times they'll start to gain weight earlier in the pregnancy. The only increase in calorie requirement is actually 100 calories per trimester. So really kind of focusing in on that, it's really not that much more than what you're eating now. If you added an apple, that would be enough. Most people feel like, you know, they've heard from the media and from society that they need to eat all of this food when they're pregnant, and they gain huge amounts of weight, but that's not normal or required physiologically. So again, adding 1 to 2 to 3 apples is really all you need. The sense of taste is going to be blunted a little bit, and so food might not taste the same, and so a lot of people just don't even have the desire to eat. And then there's pica, which you probably, again, have heard of. In the South, folks who have pica will eat clear starch. In the UK, it's more commonly coal. Also soap, toothpaste, ice. If your pregnant woman says, I'm eating all of these things, check her for anemia, because that's basically what pica is, or poor weight gain. Some of the changes to the gastrointestinal system. So women tend to be more constipated, tend to be nauseous. There's an increase in intragastric pressure. Again, increasing uterine size will displace the bowel, such that even early on, a woman feels like feel like they look pregnant, and that's because the bowel is now, when you're postprandial, your bowel is now sitting over your uterus, and so all of a sudden your entire abdomen feels like it's dilated. Progesterone will relax the sphincter, such that you're predisposed to GERD or hiatal hernia, but peptic ulcer disease tends to stay about the same or decrease. So morning sickness, very common, doesn't only happen in the morning. Usually it's worse in the morning, but it doesn't only happen in the morning. 70% of all pregnancies generally starts right around the time that you've either just figured out that you're pregnant, usually will resolve by about 16 weeks, and there's just no obvious cause for this, so we don't know what causes this. Different from hyperemesis gravidarum. So probably, I guess it's Kate Middleton. Maybe she was the one that popularized this. I remember when she was diagnosed with this and admitted, all of the media were looking for OBs to give a quote on what hyperemesis is and do we have a patient admitted. It's a pretty rare phenomenon. Very different than morning sickness, but sometimes these terms are used interchangeably. To have hyperemesis, you have to have lost weight. You have to have metabolic derangement, usually alkalosis. And there's dehydration and possible renal failure. So there's different things that are going on than just, you know, I'm a little nauseous, I vomited this morning. So it happens in less than 1% of pregnancies, and it can be very serious. We have all kinds of antiemetics that we use to treat pregnant women, but some of these women don't respond to any of these things. And in severe cases, they need to be admitted to the hospital for PICC lines and gastric feeding tubes and all kinds of other things when they just can't tolerate anything for weeks on end. And I've seen maybe 2 cases where they've had to have feeding tubes. So it's not common, but it can be very serious. Okay, hepatobiliary system. So you've got dilation of your gallbladder, the biliary system, again, progesterone mediated. Progesterone will inhibit cholecystokinin, which decreases gallbladder motility. So if you never knew that you had gallstones and then you're pregnant, you're more likely to have aggravation of that area. Alkaline phosphatase is increased, and it's excreted by the placenta. As a matter of fact, yesterday in our grand rounds, there was a presentation of a patient who kind of clearly had pancreatitis, but the medicine consultants had known that ALK phos can be secreted by the placenta, but only in small amounts. So there's just a moderate increase in ALK phos levels by the placenta. This woman had ALK phos levels that were through the roof, but they kept trying to associate that with pregnancy. So yes, it's elevated, but not in the thousands where it's pancreatitis. So just things to know about different changes, different lab results you're going to have in a pregnant woman. Total protein and albumin are always going to be decreased, and that's normal, dilutional. There's delayed gastric emptying. So if you have the need to operate on a pregnant woman, whether it's for her appendix or whether it's to do her C-section or whether it's for any type of operation, it's important that she have an empty stomach if possible. This is why, and you might hear in the lay press that pregnant women usually don't eat while they're in labor and delivery, because if they need an emergency cesarean delivery, they might aspirate the contents that have been in their stomach for 8 hours because it doesn't empty as quickly. So these are kind of the things that we do to try to protect women. Much higher risk of aspiration during surgery, particularly if the patient needs to be intubated. There's inadequate inadequate weight gain associated with growth restriction, but other factors that are associated with fetal growth restriction. And then there can be excessive weight gain, which is actually the more common scenario, and that's also associated with a whole host of morbidities. Recently, the Mailman School of Public Health had the symposium on childhood obesity, and one of the things we focused on was gestational weight gain. And really the problem is that women are gaining way too much than they need to. That leads to increased risk for preeclampsia, cesarean delivery, and just adverse pregnancy outcomes in general. Alrighty, moving on to the pancreas. Other physiologic changes. So there's hypertrophy and hyperplasia of the beta cells. Fasting is associated with accelerated starvation, such that a normal pregnant woman will wake up starving, and they'll be hypoglycemic. In general, the fasting level of a pregnant woman is going to be a few points lower than the fasting level of a non-pregnant woman. There's hypoinsulinemia and hyperketonemia that's associated with that accelerated starvation, and it's due to diffusion of glucose by the fetal placental unit. So, like I said, normal fasting maternal levels are going to be pretty low. So the response is you need to eat right away. So then all of a sudden you become hyperglycemic, hyperinsulinemic, triglycerides, everything goes up, and you have a decreased tissue sensitivity to insulin. So if you are predisposed to being a diabetic, if you have a strong family history of diabetes, or you were just on the cusp of having diabetes, and then you're pregnant, you're going to have gestational diabetes. Pregnancy will unmask these underlying things. So now with this reduced tissue sensitivity to insulin, you have the diabetogenic effect of pregnancy. And it's mediated by HPL, human placental lactogen, and then cortisol. So it's a normal change in pregnancy. Generally happens about 24 to 28 weeks gestation, but if you're predisposed to having diabetes, you'll have it. And kind of the fallacy out there in the lay world is that, oh, if you eat too much during pregnancy, you're going to have gestational diabetes. It's not related to that. It's really related to genetics. It's related to what's going on in your placenta. So some people will get it and some people won't. But there is a greater insulin resistance as the pregnancy advances, again, gestational diabetes. In terms of your thyroid, so HCG, which is the pregnancy hormone, also stimulates the thyroid gland. And it's the similarity in the subunits for HCG, such that serum TSH is going to decrease in early gestation. And oftentimes what happens is you'll have a woman who has incredibly low TSH levels, and that's when you kind of diagnose that they're pregnant because they didn't kind of realize that they were pregnant, and you see this change. Similarly, if you're trying to diagnose thyroid disease in a pregnant woman, you just don't want to test them in the first trimester because your values are just going to be off. We also use free values rather than bound because those values are going to be off. So there's rises to pre-pregnancy levels at the end of the first trimester. So if you want to check them for thyroid disease, check them in the second trimester. T4 will increase early in gestation, and the role of that is HCG stimulating the thyroid. You have a rise in thyroid binding globulin that leads to a rise in total T4 and T3. So if you're the endocrine consult on the obstetric woman, know not to order total levels, just order the free levels. So the active hormones, free T4 and free T3 are unchanged. So most women with hypo or hyperthyroidism will need a change in dose of the medications, and usually we just manage those in our high-risk clinics. All right, so we went through all of the physiologic changes and trying to remind you of some of the things that you might see, whether you're an obstetrician or not, particularly pulmonary embolism. And why do I keep talking about pulmonary embolism? Because it is one of the most common causes of maternal mortality. So it's really something that we should not avoid. And let me see. So these historically, hemorrhage, pulmonary embolism, and then hypertensive disorders of pregnancy are going to be your three most common killers of pregnant women. I was having a conversation maybe 5 years ago with a pediatric cardiologist who was shocked that pregnant women still died. And I said, whoa, you're a physician, you should know that this happens. So, and one of the things that we all need to really look out for, particularly the pulmonary embolisms are going to occur sometimes outside of the, obstetric cough coifers, and so you guys need to be able to identify these women for us as well. Hypertensive disorders of pregnancy, if you see a woman with a severe headache and elevated blood pressure, she needs to come to OB right away. And then hemorrhage. Hemorrhage is something that we usually have on our side, usually postpartum, but bleeding pregnant women, these are going to be your three most common causes of death historically. And now, newer would be cardiovascular conditions because we've become so good at treating them that now these women who initially would not live to have a pregnancy or were too sick to have a pregnancy, now with all the interventions we have pregnancies, and then we need to manage them. So this has become now a more common rising cause of maternal mortality as well. And unfortunately, cardiomyopathy has become more common, partially because pregnant women are getting older, but this is now more common. And now these are numbers from New York City. So in New York City, the most common cause of death, again, is an embolism, pulmonary embolism, number 1. And then hemorrhage, number 2, pregnancy-induced hypertension, preeclampsia, that's number 3. And then pretty much most other things are going to be a little bit less common. Infection is there, but then cancer, anesthesia, injury, these things are less common. But just things to keep in mind. Okay, so I was also asked to speak a little bit about labor and delivery, again, because this is your pregnancy lecture. So this is going to be the Cliff Notes. Certainly, there's a lot more to labor and delivery than just these few slides. But if you have any questions about anything, I think you guys are a little bit more savvy in that some of you come to our labor and delivery unit and see a couple deliveries. We're always happy to have a first-year medical student. We get excited. You know, we're dull people, so, oh, there's a first year, yay, and then we show you stuff. So encourage folks to keep coming by. We'd love to have you. Anytime you want to come, we're there. All right, so how do you define labor? Labor is progressive dilation of the cervix in association with repetitive uterine contractions. Essentially, contractions that are causing cervical change is labor. You can dilate without having contractions, and that might be cervical incompetence. That's actually not so common. Or it just might be normal, as long as you don't dilate to fully dilated. Or you can have contractions without dilation, and then that would be latent labor. And that's very, very common in late pregnancy. And I think every pregnant woman has heard of the term Braxton Hicks contractions, which essentially means nothing if you don't go on to deliver. They are real contractions if you go on to deliver, which is what I always tell women. You can only diagnose those in retrospect. So what is cervical dilation? Basically, the opening of the cervix measured in centimeters, with 0 being completely closed, and then if you've got 1 to 10, these are not obviously to scale, but so we just examine that digitally, so all obstetricians know that, oh, this is about 7 to 8 centimeters, this is fully dilated, this is going to be 2 to 3 for me, and that's how we assess. For the vaginal exam, we figure out how dilated somebody is. Usually, a cervix will efface before it dilates, but not always. The cervix has not read the textbook. So effacement is measured by the percentage of cervix that is thinned or shortening. So this is considered, so if this here, these two areas are here are the cervix, this would be considered a long cervix, and that's about 3 to 4 centimeters. Here, you can see it's starting to dilate a little bit. That's about 50% effaced. And then here is completely thin, so that would be fully effaced. So effacement is essentially thinning. And here is, I think, a better pictorial. So this, again, is the cervix. Here's the uterus here, baby in the correct anatomical position. Cervix and vagina over here. This is not effaced at all, so it's both completely closed and very thick. Versus over here, you can see it's starting to efface. That's probably about 5 to 6 centimeters dilated there, and it's pretty thin. So that's effacement. In terms of station, now station is something that, particularly as you're starting to learn this, is a little bit more nebulous. But basically, over here, these are the ischial spines, if you recall from anatomy. So that's actually 0 station. So what you're doing is you're measuring the relationship of the head to those ischial spines. So you kind of go in digitally, feel around for the spines. Once you feel the spines, then you see, well, where's the baby's head? If the baby's head is kind of right there, you're not going to feel the spines, and that's going to be about +3 station. If you feel the baby's head at the level of the spines, that's 0 station. And then minus would be above that station. So in station terms, minus is bad, plus is good, and 0 is right at the level of the ischial spines. So what we're talking about is the degree of descent of the presenting part. It used to be that we divided the pelvis into thirds, and so it would be kind of 0 would be here, and then, it would be a gestalt. There has been a move to use centimeters such that you'll sometimes see -5 and +5, and that's with using the centimeter method, but most people will still just use 1, 2, 3, and not go up to 4 or 5. If the head, there's other terms that we use, so if the head kind of comes down to here, but you can freely move it, then that's called balaudable. So it means that the head is kind of floating. Or just out of the pelvis, and that's going to be even higher than -3. All right, so what we can do is we can kind of put all of these things together into what's called a Bishop score. There's been a lot of literature looking at the Bishop score, and basically the purpose of the Bishop score is to see both kind of the likelihood that you'll have a vaginal delivery. The higher the Bishop score, the higher the likelihood, and also whether you need, what kind of induction agent you would need. So if your Bishop score were less than 7, you would need a ripening agent, and if it were more than 7, then you might just need augmentation. So that's kind of the Bishop score. I mean, we don't necessarily go and write all these things down and stick to them, but that's what it reflects. And then labor is divided into stages. So the first stage is going to be actually both latent and active labor. Latent labor kind of ends around 5 centimeters, and these definitions have kind of recently changed over the past 2 years or so. Active labor starts at about 6 to 10 centimeters, and that's when labor moves more quickly. The second stage of labor then is from the time that you're fully dilated until you deliver the fetus. So that's kind of the pushing stage. And then the third stage will be delivery of the placenta. And it's actually during this stage that you have your highest incidence of postpartum hemorrhage. And so in the lay press these days is delayed cord clamping. Should we delay it? Should we not? And kind of obstetricians have been taught usually not to delay it for the purpose of preventing this postpartum hemorrhage. Because the thought is that if you clamp the cord right away, you can manage the delivery of the placenta and prevent that hemorrhage from happening. You're not going to know who's going to hemorrhage. It just happens. The faucet's open. But you know, the thinking is now that there might be some fetal benefit even at term to delaying cord clamping, and so that changes slightly how we manage the third stage of labor. And then there are all these kind of paradigms about what normal labor should be. So the duration of the first stage in a primipara, which means someone who's never labored before, first pregnancy would be about 20 hours. In a multiparous woman, someone who's had more than one pregnancy, that's 12 hours. And then in terms of dilation, these are thought to be the minimal values per hour in these different, in the active phase. And then in terms of second stage, so pushing, generally it shouldn't be more than 3 hours in a primiparous woman and shouldn't be more than 2 hours in a multiparous woman. So labor is a long process, and what I tell most women is that generally 24 to 36 hours is normal. And the third stage of labor should be 30 minutes is kind of where it's capped at. All right, and then finally, last thing, labor curves. Kind of the reason I put up this slide. So labor curves are actually defined. You'll probably be required to do a Friedman curve when you come to L&D, and Friedman curves have been used all around the world. Friedman was a medical student here, and he defined the curves when he was on the rotation, and then stayed with us and was a resident in OBGYN, so great things that you can do as medical students. But so this curve, basically what it shows you is that the latent stage of labor is very, very long, and then somewhere here around 5-6 centimeters, you start to go into the active phase, which then increases in terms of dilation, and then there is delivery. So that is pregnancy in a nutshell. Thank you very much for your attention, and I'm very happy to answer any questions. Anybody? Yes. Resolve. Okay. So great question. We didn't talk about incidences at all, but depending on your population, about 5 to 10% of women will develop gestational diabetes. Of those, the majority resolve postpartum, but they have about a 50 to 60% lifetime chance of getting overt diabetes, usually by 5 to 10 years. Yes?
When I shadowed in labor delivery, I saw 2 women go into really, really terrible hypotension after they delivered, and I was curious what the normal cause of that was.
So if it's after delivery, it's probably postpartum hemorrhage that's unrecognized, and that they've been bleeding at some point throughout the pregnancy and become hypotensive. It's actually fairly common after an epidural is placed, immediately after an epidural is placed, to have hypotension also, and that's because of just vasodilatation after the epidural. And so a common practice is to bolus someone before you give them an epidural, but if it's postpartum and they're hypotensive, it's probably postpartum hemorrhage. Okay, looking forward to seeing you guys on the wards. I'm handing you a baton.
Birth and birth control. Good to have back to back.
I know. I know there's some family planning people and some other people that are going to talk to you.
Definitely. How are you?
Good, how are you? Like whatever they say.
Just yeah. She's right. I didn't know Friedman was a medical student. Yeah. How great is that? That's cool. You know. What a good idea to put a graph out of that.
One of our residents might try to redo the clinic there since they were done at the Oakland Hospital. With our new,
Yeah. I wonder if it's different. We wouldn't have as much data. Section. Are you helping out with the... Oh, hello, how are you? Good morning, good. So I have this on here. All right. Oh, look at that. You guys have a touch screen. Aren't you guys cool? Wow. Easy. Can I do it? Sure. Can I and can I are two different questions, right? This one? Is that the... Oh, there we go. Look at that. That was easy. Wow. All right, cool. Terrific. Or can I use... is this better than this? Which one is less likely to give feedback? Is that what Cynthia was using just now? Okay, that's fine. We can use that then. All right. When do you guys start this lecture? 10. Okay, great. All right. Sound good. Cool. I'm good to go. Good morning. I'm going to go ahead and get started. Is this loud enough? Can people hear me? We're good? You can all hear me? Good? Okay, great. I guess because you're getting quiet, you can hear me. So my name is Ann Davis. I'm faculty here at the Medical Center in the Department of OBGYN, and I was a student here. That was interesting to learn that the Friedman curves came from a medical student. That was pretty great to hear about that. That's something that's such an essential part of what we do. And I always like to start this lecture just by reflecting on how things have changed at Columbia. So when I was a student, first of all, nobody had a laptop, right? We were all writing on paper furiously, although I think we could goof off just as much as you guys can goof off online. I think your goofing off is just more fun than our goofing off was back then. So at the end of the street, you know where the Starbucks is now, there was to show you how things have changed, there was a foundational garment store. Do people know what foundational garments are? Girdles and bras and support hose for nurses. So there was a nurses foundational garment store on the corner where you all go and, you know, get your mocha frappuccino. And between here and there were tremendous numbers of, well, it was during the cocaine epidemic, crack cocaine epidemic when I was in school, and people would routinely walk up to you and offer you things to buy. And one particular instance, someone offered to sell me some little white, rocks in a little vial that was about this big for 75 cents. And I thought that was pretty funny because why would I take a drug that only costs 75 cents? I thought, there's nothing in that, or whatever in it is probably not going to work, or it's pretty dangerous. I'm not taking it. So anyway, 75 cents was still cheap back then. So things have changed a little. There was also multi-drug resistant TB rampant through the building. It's the Armory now. I don't know if they teach you about that. Yeah, so that's an interesting story. So today I'm going to talk about hormonal contraception. This is an important part of my practice. I see a lot of women with complex medical problems who come to me for consultation on contraception. One of the reasons I like giving this lecture to all of you is because this is one of the few medications that many of you have taken or have a partner who has taken. So this is something that's already familiar to many of you, probably more than any other medication that we prescribe, because contraception is just so widely prevalent. So many people use contraception that many of you have already used it and know a little bit about it already. And it's something that you're going to get asked about by your friends and your family. People always have questions about contraception because we need it so much and we all use it. So here's my disclosures. I do get a little research funding from industry, and I serve on the adjudication committee for a pharmaceutical company for research. So these are the objectives of what I'm going to talk about. I want you to understand a little bit about what's in hormonal contraceptives, how they're put together, what they do, how they work, how they're combined together, and then how do they prevent pregnancy. If this is the few of these things you can remember from this lecture, you're going to know more than the national media already about how birth control works. There's been a lot of controversy. I have a whole lecture just about the controversy related to birth control, which would be for another time, but it's actually a lot of fun just to sort of think back about what's happened through the years. And then I want you to be able to talk a little bit about or understand a little bit about some of the non-contraceptive effects that come along with hormonal contraception. So as long as people have been getting pregnant, people have been trying not to get pregnant. Okay, so these are some examples of, through the centuries, things that women have used in order to avoid pregnancy. I think it is funny to sort of look back on some of these things and think about them. People used to put little charms, pieces of cats was one, cat testicles, cat liver inside of a little tube and tie it around their body thinking that that would work as birth control. People would drink potions, sort of like the periodic table. People drank arsenic, lead, mercury in order to try to prevent pregnancy. People put all kinds of things inside the vagina, even the famous Egyptian example of crocodile dung. And as you can imagine, these things were sticky and smelly, but they didn't work very well, and some of them were, frankly, quite dangerous, which is sort of testament to the ongoing willingness of women to take risk to avoid pregnancy at all costs. So the birth control pill has been around for more than 50 years. That's me, in case you can't tell from the picture. It's a little outdated, but still, I am under 50, just barely. So the birth control pill has been around for half a century. It's a medication that was really a groundbreaking medication in many, many ways. It was very revolutionary. So unlike the birth control methods that I showed you before, it actually worked. It was highly effective. It was completely reversible. So there was sterilization, but sterilization's not reversible. It was separate from intercourse. It didn't involve a pessary or some kind of condom. It's ironic, I think, and this is an interesting thing to sort of, again, reflect back on. Birth control was developed by researchers who were putting their projects together in the state of Massachusetts. In the state of Massachusetts, it was illegal to use birth control if you were not married until 1972. So the birth control pill actually came on the market before birth control was actually legal to have. And think about how radical that was for the researchers of that day to risk their careers doing research on something that people really needed but was illegal to have under certain circumstances. The early chemistry related to the birth control pill was largely focused on progestins, which came from the Mexican yam. When you read back about how the first scientists figure out how to get progestins, there's these interesting stories of him going to Mexico and looking for these plants and then collecting them in great quantity to try to extract the progesterone. So just a little bit of history. So again, birth control was considered obscene. It was banned as the birth control itself. Dispensing it was banned, as well as any information about it. So there was a gag law on physicians back then that they couldn't talk to women about birth control. That was considered obscene and was illegal under the Comstock law. This is Anthony Comstock. Anthony Comstock had it out for birth control. He also had it out for lots of other things that he considered to be obscene. So once he got rolling on pornography, then he decided to include birth control along with that. And those things were banned in federal legislation in 1873. So in that context, during that time, since fertility was basically uncontrollable for women, there was a lot of poverty related to uncontrolled fertility, which is still the case in lots of parts of the world, right? So Margaret Sanger, this is her clinic, her birth control clinic. She opened it in 1916. Now, mind you, there wasn't much you could do for birth control in 1916, but there was certainly advice that you could give and some primitive sort of diaphragm devices. And Margaret Sanger did something very radical, which was to open a clinic that was dedicated to providing birth control. The clinic was closed 10 days after it was opened, even though there was a long line of women outside seeking help. And she was arrested and jailed, and that happened to her multiple times. But eventually things moved forward, and finally in 1972, this is Griswold versus Connecticut. This is Estelle Griswold. These are some of the, she and a colleague of hers who were working at an early version of Planned Parenthood are flashing the victory sign for this decision. This decision allowed married people to use contraception. And then in another decision in 1972, unmarried people could legally use contraception. So that was in 1972, not that long ago. So these are the people that made modern contraception possible. Again, Margaret Sanger was the visionary who sort of saw the need and moved it forward. They had a funder, Catherine McCormick, and then Gregory Pincus, the scientist, and John Rock, who's a clinician who did the research. And the research was so controversial in the United States that they had to move it to Puerto Rico. So controversial times even back then. So birth control continues to be controversial. I'm sure you've seen stories in the news about some of the controversies relating to coverage of contraception and the implementation of the Affordable Care Act, and lots of controversy about that. Should it be paid for? Should it be included in some of the covered benefits, preventive services? As it stands now, contraception is considered a preventive service. Surprise. And under that decision that was made with the Obama administration and the ACA, you should be able to get contraception without paying additional money for it past what you pay for your usual health insurance. So it isn't free. There's no free contraception coming from the government. All the Affordable Care Act says is that if you have health insurance, that your insurer has to cover it without additional cost to you, beyond the cost of your premium. So for those of you who use contraception, hormonal contraception, you should be able to get it from the pharmacy without a copay. And if you're still paying a copay, ask me how you can not pay that copay. It should be covered for you. There's also a change, a little bit of a sea change going on in the United States, and certainly among the medical students and graduate students and nursing students in my practice. I'm seeing this as well, which is that people are moving away from the short-acting methods of contraception and moving more towards long-acting methods like the IUD and the implant, which last for a period of years as opposed to 1 month at a time. And there are a lot of obvious benefits to those for young people such as yourselves who don't plan pregnancy for a long period of time. Contraception is, as I said, very, very popular and commonly used in the United States. This is a little bit of a joke, this slide. The data is not a joke, but the scale and the graph, I modified it slightly to make my point. So if you look at the legend over here, you know, I gave you the 4 colors. This is over 75%. This is data from the CDC, and the more recent data would be exactly the same. This shows that pretty much a giant majority of people, no matter what state you're in, and all the states are the same, be it Nebraska or New York or California or Arkansas or Florida, that a majority of people who are at risk for unintended pregnancy use contraception. The average woman in the United States uses contraception for about 25 years of her life. Okay, so I sort of call contraception a life project because people need to use it for so long, and that makes sense. If the average person has about 2 children, she goes through menarche at 14, starts having sex around 18, 17, 18 is the average, and goes through menopause at the age of 50. There are going to be many, many years where she's trying not to get pregnant. So contraception, wildly popular across the board, bipartisan support for contraception in terms of who uses it. We all pretty much use it. The most popular method of contraception in the United States remains the birth control pill. This is just a slide to show you that there are many, many different brands and formulations of the birth control pill. Certainly it isn't important to wrap your mind around all of these, but it is important to understand what's in them and how they work. 85% of women in the United States will use the birth control pill at least once in her life. Okay, so super, super common for people to use oral contraceptives, 85% of us. So what's in them, oral contraceptives? There's 2 things in almost all oral contraceptives. They have an estrogenic component and a progestin. Those 2 things are combined together. And the reason that they're combined together, you could just give progestin, that would work as contraception, and that's what they did with the early birth control pills. But then it was understood, that estrogen helps, a little bit helps for contraceptive efficacy, but mostly helps for cycle control. If you give progestins all by themselves over a period of time, irregular bleeding can occur. If you give estrogen with the progestin, you can diminish the irregular bleeding. So estrogen is added in so that women are bleeding at predictable times as opposed to unpredictable times. So there are some birth control pills that have only progestin in them. Okay, that's called the progestin-only pill. Has no estrogen. There's no pill that has only estrogen in it. That would be carcinogenic to the uterus and as well wouldn't work and would be a little bit more risk. So by using a small amount of estrogen and the right amount of progestin, we get a highly effective method that's safe. Again, no estrogen-only pill, but we do have some progestin-only pills. Dr. Gyamfi, who was here before, was talking about labor and delivery. Progestin-only pills are a popular method for women postpartum because they don't increase the risk of thrombosis. And deep vein thrombosis and pulmonary embolism, the risk of that in pregnancy peaks right around the time after delivery. So women need a method that's safe after delivery that isn't going to increase their risk of thrombosis even beyond the very high risk being related to postpartum. This is just a little bit of cartoons to show you what these molecules look like. They're familiar to you as steroid molecules with the backbone. There's only 2 kinds of estrogen that's in birth control pills in the United States. Ethinyl estradiol, which is by far the most commonly used estrogen. It's more potent than natural estrogen in our body that the ovaries produce, so only small amounts of it are needed for contraception. And then we have another newer molecule, This one, estradiol valerate, that one is less potent than ethinyl estradiol, can be given in smaller doses. It remains to see whether it's safer, but it's closer to our own endogenous estradiol, so it's certainly marketed as something that's more natural. Whether it turns out to be safer remains to be seen, we'll see. So there's a lot more variety related to the contraceptive progestins, and again, they've been developed. This was the first part of hormonal contraception that was developed from the Mexican yam. And they've been working on that, as I showed you, from the 50s. And then in a series of experiments, it was necessary to figure out how to change the molecule to make it orally absorbed. So why don't we just give people regular old progesterone, right? We can make progesterone, natural progesterone. Natural progesterone, if you take it by mouth, is degraded. It doesn't work. So you can't take progesterone orally. If any of you have family members who've ever gone through IVF, you know that people have to get shots, progesterone shots. It's because you can't take progestin by mouth, okay, progesterone by mouth. So the molecule progesterone was modified to make it orally available, so that's why it's different than natural progesterone. And the first progestin that was developed is this one, norethindrone. You can see here, that's our sort of classic contraceptive progestin. Been around for decades, and it's still part of marketed birth control pills in the United States. It's safe, it works, and we're familiar with it, and probably some of you have taken it. This is a little cartoon of how the contraceptive progestins are related. You can break them up into families and group them as molecules. I think the important part of this is to understand that these things have come in waves. So the first contraceptive progestin was norethindrone, and then after that we have the levonorgestrel family. So these are now some of the older progestins, but available in many marketed birth control pills: levonorgestrel, desogestrel, and norgestimate. So these might be familiar to some of you as birth control pills like Ales, Levlite, Avril, low Avril. These are things you may have seen at some point. This one, Desigen. This one, orthotricycline low, Sprintec. So see, these are some of the pills that are still around and widely used. And then we have, these are the older ones that we already talked about, norethindrone. And interesting, norethindrone is, while it's the oldest progestin, is the one that's in the most commonly prescribed marketed pill in the U.S. today, which is something called low estrin. I bet some of you have taken that too. So here's more progestins. So things have continued to change. We have our first wave, the norethindrone, then the levonorgestrel-related molecules, and then here are some that are also familiar to you. This one here, drospirenone, that's what's in Yaz and Yasmin, or Gianvi and Ocella. Those are the generic names for those. So drospirenone is our most recently developed progestin, obviously still on the market, and lots of people use it. So why do we have all these different progestins? What's the point of all this? If we had one in the beginning that worked and it was safe, why do we keep changing it? So the reason is because the progestins have different properties. So it's important to understand that if you take two birth control pills with different progestins and try to compare them, if they both have ethinyl estradiol, you can certainly compare the dose across pills. But if you say, oh, I want a low-dose pill, this one has norethindrone and this one has levonorgestrel, you can't actually compare them head-to-head because they have different properties. They have different potency, binding to receptor, they have different bioavailability. So they're really different molecules. So even though they're in the same family, the doses are going to be a little bit different to accomplish inhibition of ovulation, and also with some of the side effects people experience when they say to me, you know, what's the lowest dose progestin? You really have to look within the particular kind of progestin, that lowest dose. You can't compare progestin across progestin. It's important to know that the bioavailability of these is really different. So you can see that our down here, norethindrone, for example, remember our old progestin that's been around forever is only 60% bioavailable, even lower for norgestimate. So since the bioavailability here is a lot less, you have to give a higher dose, for instance, because of what's happening in the liver with absorption. All right, so why do we keep developing different kinds of progestins? To improve the bioavailability so that the dose can be lower. And again, milligram to milligram comparisons are not meaningful across the progestins. So this is to start to explain to you how birth control pills work. So remember the menstrual cycle, the very complicated menstrual cycle. I remember when I was learning about it as an undergraduate, I took a course called, I think it was like reproductive endocrinology. I think I knew what I wanted to do back then, even though I didn't know what I wanted to do, right? It's funny how you get interested in things and then you sort of follow a path. And I remember trying to learn about all those feedback loops. First time trying to learn about all the feedback loops and how it is that one thing inhibits something in your brain and then how all the tropic factors go back and forth. So you really need to understand that to understand how birth control pills work, okay? So we're going to talk about that more so that you really understand it. So the main thing that birth control pills are doing, their main mechanism of action, is that they inhibit ovulation. So that makes sense. If no ovulation occurs, pregnancy cannot occur. Oftentimes people will ask me about male hormonal contraception and why isn't there male hormonal contraception. There is some, and people have been working on it for decades. It works by the same principle, which is to inhibit spermatogenesis. However, millions of sperm in one ejaculate, one ovulation per month. It's a lot easier to inhibit ovulation than it is to develop a product that's going to completely inhibit spermatogenesis. So that's one of the reasons that we don't have effective male hormonal contraception. People are still working on it, but there may be a totally different way of looking at that we don't really know now. Maybe there's other things we can do to inhibit the capacity of sperm to fertilize the egg, change capacitation, sperm function, the acrosome reaction. Those kinds of things may be more productive in the end than trying to completely inhibit spermatogenesis with hormones. So as I mentioned about the progestins being different, here you can see that the molecules are really different in their ability to inhibit ovulation. So you have to give a lot more norethindrone to inhibit ovulation than you do levonorgestrel. Understand also that these molecules themselves are not related to the risk of thrombosis. That's something that's really related to estrogen, which is the main risk associated with birth control pills, the increased risk of thrombosis. So even though we're putting a lot more norethindrone in a pill than levonorgestrel, we're not increasing the risk of thrombosis because progestins don't increase the risk of thrombosis. They have very different half-lives. You can see the drospirenone, which is our most modern contraceptive progestin, has a very long half-life. Why is that a good idea? Anybody why would it be a good idea to have a long half-life? Perfect. If you miss, who said that? They miss a pill. Right. So if you miss a pill, do you think people miss pills? As a comparison, and we're preventing something with pills, so it's harder to stay motivated to do something when it prevents something, right, than it is when you're treating something. If something hurts or something is happening right now, you're going to take medicine for it. If you're trying to prevent something, it's a lot harder to get yourself motivated to do it. There's nothing special about birth control. People forget their medicine. For every medicine that we prescribe, whether it's the medicines you take so you don't reject your transplant, that one was always amazing to me. There would be people who'd say, yeah, I just forgot to take my, my drugs to reject my, and now I'm rejecting my transplant. Insulin, people don't take, right? There's lots of medicine that people don't take. And any of you who have a chronic medical issue where you have to take medicine every single day forever, it gets old, right? And sometimes you forget about some of this stuff and you just don't do it. Same for birth control pill. People certainly forget pills. And if you forget pills, then the inhibition of ovulation starts to be released and ovulation can occur. It usually takes missing a few pills, though, before that's going to happen. So there is some clinical relevance to this. It's not all just pharmaceutical marketing. Pills, this is a sort of a complex slide. Don't worry about really the details of it. The point is that the pills with the longer progestin half-lives are a little bit more effective at preventing pregnancy. Okay, so it is better in terms of preventing pregnancy to have progestins with a longer half-life. There are some new contraceptive steroids under development. Again, I talked about the pills with the more natural estradiol that's being developed. I don't think we need to focus too much on these. Just to say that this is happening, there's always new ones coming down the line. And really now the focus is really on trying to reduce that risk, a small increased risk of thrombosis, which is related to pills. Pills are very, very safe, but thrombosis can be a life-threatening event, like a deep vein thrombosis or a stroke. And while a DVT is only going to occur in about 1 in 1,000 users, it's still going to happen, so we still try our best to change the medicine to reduce that risk. Okay. So let's talk about real life things that happen with birth control pills. Are people going to get pregnant when they're taking birth control pills? Not usually, but if they miss their pills, they will, right? And if you miss a couple of pills and you get pregnant and you don't quite figure it out right away, which certainly could happen, you keep taking your pills, certainly many pregnant women early in pregnancy have been exposed to these particular contraceptive steroids. It's important to understand that pregnancies, when they occur in the context of taking oral contraceptives, are not exposed to any kind of teratogenic effect, okay? So birth control pills don't cause birth defects or problems with embryonic development. Obviously, you don't tell someone as soon as you figure it out to stop taking it because it's not doing you any good, and we don't want to expose your pregnancy to any risk at all if we can avoid it. But certainly no need for additional testing or workup or advising to not continue the pregnancy based on having been exposed to oral contraceptives or the depot shot or the implant, any of them. They're all not teratogens. When people take birth control pills, one important thing that happens is there are changes in binding globulins that are related to the the estrogen exposure. The biggest one is serum hormone binding globulin goes up quite a bit. And some of those effects cause some effects that are meaningful, and some of them are not meaningful at all. One thing with the thyroid, often when people take oral contraceptives, they're getting their thyroid tested for some reason. A lot of doctors do this routinely, check people's thyroid parameters. Some of the changes of binding globulins will change some of the results of thyroid testing. It's important to know, though, that the TSH does not get changed at all. So if a woman's on birth control pills, you can still do an assessment of whether she's hyper or hypothyroid with a TSH as a simple test. There are small changes in cholesterol when women take hormonal contraceptives. They're not clinically meaningful, and they certainly don't put anyone into a category of needing treatment. Same thing happens with glucose measurements as well. There are small changes, but not a clinical impact. One change in binding globulins that is clinically important is that the increase in SHBG binds testosterone, removes free testosterone from the circulating system, and that reduces acne. So we certainly use birth control pills as a treatment for acne. I don't know, do you have that dermatology lecture? Does she talk about that? I think that was part of this block last time. So birth control pills are effective for that reason. They increase the binding globulins, decrease serum testosterone, and that decreases the testosterone-related hormonally driven acne. Birth control pills are approved for the treatment of acne by FDA, so they've been compared to placebo and they work. Certainly women take them for that purpose as well as for contraception, so that was one of my objectives of the lecture, right, is to understand that there's birth control you get from pills, and also you're going to get improvements in some of these other health conditions, and acne is one of them. Certainly younger women, that's more of an issue, so that's a nice health benefit that they get. So as I mentioned, birth control pills inhibit ovulation. That's largely how they work. They cause other kinds of changes too. The two most important for contraception would be inhibition of ovulation and then changes in cervical mucus. So you may remember from your learning about the menstrual cycle that over here you can see, so what happens at the beginning of the menstrual cycle here, FSH is going to go up, and then you're going to have the LH surge, and then the ovulation is the green line. So FSH goes up. What does FSH do? It stimulates follicles, right? So you're recruiting a dominant follicle for ovulation. And then when the LH surge occurs, ovulation occurs, and then pregnancy can occur. Progesterone goes up after ovulation. So here you see what happens to the endometrium during that time. So what birth control pills specifically do is that the estrogenic part of the birth control pill inhibits FSH, right? So that's that feedback loop that occurs. The estrogen in the pill inhibits your pituitary to not make FSH. If FSH isn't being made, there's no recruitment of the dominant follicle. It's kind of like you're in a way pregnant, right? No one ovulates when they're pregnant. So it's sort of a signal going back to your brain to say, no FSH, no gonadotropin, no ovulation, no pregnancy. And then the progestin part inhibits the LH surge. Okay, so the estrogenic part inhibits the FSH, you don't have recruitment of follicles, and then the progestin part goes back to your brain and inhibits the LH surge at the level of the pituitary, and then no ovulation will occur. So as long as those things are happening, pregnancy can't happen. So there's no recruitment of the dominant follicle, and then no ovulation because of the suppression of the LH surge by the progestin component. Cervical mucus is also thickened by progestin. So if cervical mucus is thick, it becomes impenetrable to sperm, and that's what happens anyway in the second half of the cycle. Progesterone does that. So you may have learned about fertility, that in the mid-cycle where there's a lot of estrogen around, cervical mucus is stretchy, watery, slippery, and then it changes into progesterone here, thick, sticky, tacky, so the sperm can't get through. So if you're taking a progestin all through the cycle, the cervical mucus becomes impenetrable to sperm. So two major things going on, mostly inhibition of ovulation and then also changes to cervical mucus. Anybody have a question about that? Is that straightforward? It's amazing someone figured it out, isn't it? Not someone, a lot of people. So this is just a summary of some of the things that are happening. You could look at this on your own. There's also, other changes that occur related to taking hormonal contraceptives. One of the ones that's a good thing is that the endometrial lining really thins because of exposure to progestins. And why is it good to have a thin endometrial lining? Because then you don't bleed as much. So without the proliferation effect from the estrogen, there's opposition to that with the progestin, and then during the menstrual cycle there isn't as much bleeding. So that's great. So when people have heavy menstrual bleeding, they can also expect an improvement in that from birth control pills. So birth control pills are approved for that purpose as well by FDA, which is to treat heavy menstrual bleeding. Menorrhage is another name for that. So that's another non-contraceptive benefit of taking pills, improvement in menstrual bleeding. And also dysmenorrhea improves on pills for some complex reasons, but another thing women can expect. All right, so bleeding that happens on birth control pills, this is often confusing, and so I like to just kind of say it clearly what's really happening. So if you think about that menstrual cycle cartoon, the estrogen's in the beginning, estrogen builds up, progesterone kind of stabilizes it, and then at the end of the cycle, they both drop, and the endometrial lining is shed, and there's menstrual bleeding, okay? So in a spontaneous cycle, no other hormones on board, there's ovulation, proliferation of the endometrium, and then at the end of the cycle, bleeding. It's spontaneous, happens all by itself with all that complex combination of things. But when you're on birth control pills, why is there bleeding? If you don't have the estrogen building up as much and you have progestin all through the cycle, why is there bleeding? It's really just because of the withdrawal of the hormones at the end of the cycle, okay? So you take the pills for a certain amount of time, you stop them, kind of like what happens at the end of the menstrual cycle, and then there's bleeding at the end. So it's a withdrawal bleed. It's not because you had ovulation, you didn't have ovulation, you don't have all the FSH and estradiol going up, but you do have that withdrawal at the end. So really you can change that, unlike your own menstrual cycle where you can't say, I'm going to bleed on this day. You can with birth control pills because you can stop the birth control pills at any time, and then bleeding will occur after that. The reason that birth control pills were designed to be 3 weeks on and 1 week off, to have 1 week off where you would bleed for about a week, why do you think people made pills like that? You could have made them anyway. You could have made them 5 weeks on, 1 week off, 6 weeks on, 2 weeks off, 1 week off, or else you'd ovulate. But why do you think they did that? To make it acceptable. So remember how controversial it was back then to have birth control at all, right? It was still illegal when the pill, in some places when the pill came on the market. So John Rock, who was the clinician who sort of guided them through the research process, said, let's make this a lot like what happens in a normal kind of typical cycle so that it'll be more acceptable to people and it'll seem less controversial. They didn't want it to seem like they were really changing nature too much. So this is, again, what happens during the normal cycle. And so here you can see what happens with the pills themselves, right? So this is just a typical pack of birth control pills, if anyone's never seen a pack of birth control pills. So the blue pills are the estrogen and progestin combined, 1 week, 2 weeks, 3 weeks. And then during the last week, there are these pills. What's in those? Nothing, right? They're just, placebo pills. You could call them sugar pills. I don't think there's actually sugar in them because they don't taste good. So they're just pills with some kind of inert. Sometimes people put stuff in them as a marketing ploy, like folic acid or some other stuff, but there's nothing in them that's active. There are pills now, more modern pills, where you've got 24 days on and only 4 days off. Why do you think they did that? Shorter period, right. So instead of the 7 days of bleeding, only 4. So the 24-4 model right now is one of the That's one of the most popular, and that's, I think, eventually will just be kind of how everybody does it, because nobody wants to bleed longer than they have to. Although, why do you think people would like to have some bleeding? Some people would like to have some bleeding every month. So you know you're not pregnant, right? And then you're not running over to CVS having a panic attack when you don't get your period, thinking maybe I missed one and now I'm pregnant, uh-oh. So you don't want to be going through that either. Okay, so historically the dose for a birth control pill started really high with estrogen, okay, and then it's been gradually reduced. And what was the problem with the high estrogen dose? Remember what I told you what the risk is? Clots, okay? So we had a problem with clots, heart attacks, strokes related to very high doses of estrogen. So the doses have been gradually lowered, and there's been improved safety with the gradual lowering of the estrogen component of pills. In 1968, fewer than 5% of pills had less than 50 micrograms of ethinyl estradiol. By 1998, 30 years later, almost all of them did. So there's been a huge change. And the lowest dose pill now is a 10 microgram estrogen pill, which is this one here. I just put this in here. Let me make sure that's right. Yeah, so this is low estrogen. See, there's that little name right there. So this is all the estrogen, progestin part. And then there's this little, I don't even know what's in here. I think it's a couple days of just estrogen and then 2 days off. So you see how they're getting fancy now, right, with all this. But this is the important part, is the inhibition of ovulation here, and then, you know, you have a short period. And Ovid was the first birth control pill that was put on the market. I love the bottle that it came in. But it had, so this has 10 micrograms of estrogen. This had, I think, 80. So 150 of mestranol, but mestranol is half as potent, so you needed twice as much. So I was about right. Okay, so a lot of estrogen back then, a lot less estrogen now. And there's nothing surprising about this. All kinds of medicines, you start out with a certain dose, and then, you know, you work your way down once you figure out it works. We do that with lots of different medicines. So how are birth control pills metabolized? By the liver, like most drugs. The liver is the central location of drug metabolism, and they do have a first-pass metabolism through the liver, and they're metabolized by the hepatic P450 system in the liver. So there is a much concern about clinicians across the board about what birth control pills, how birth control pills are going to interact with other medications. Most of the time people are a little over-worried, but there are some things you should worry about. Most medications don't interact with the birth control pill in any way, but there are a few that do. If you have a woman who's taking drugs for seizures, that's something to be very cautious about. There are some that really do increase the P450 metabolism system. They enhance it so that all medications that go through the P450 system are metabolized faster. Those drugs these are some of the old ones. Not too many people take these anymore. Carbamazepine, that's Tegretol. Topiramate, Topamax. You've probably seen that around a little bit. Oxcarbazepine is Trileptal and Felbutol. So when people take these, it's going to increase the P450 metabolism, and P450 metabolizes pills, so what's the consequence of that? There's less contraceptive steroid around to inhibit ovulation, and pregnancy can occur. So if you have women who are taking these, you have to worry about their hormonal contraceptive not working. There's a few things also used for other medical problems. Rifampin is used for tuberculosis. You'll see that occasionally, or people who are being treated with TB. Griseofulvin is used for fungus. Okay, so these do the same thing. And St. John's wort also, which is used for depression and is a OTC supplement. So worry about those. These are, as I said, most drugs don't do this, okay? So it's kind of a short list of things that do. These are the ones that don't. And the important part of this is that commonly used antibiotics do not increase the metabolism of birth control pills and don't decrease their efficacy. So if you have a patient, you see she goes through the emergency room, somebody puts her on Bactrim, she's taking her birth control pill, and she'll say, what should I do with my birth control? Nothing. Keep taking it. Certainly people will worry about this, and I've done an abortion for more than one person who said, they put me on this antibiotic, so I stopped taking my pills because I knew my pills weren't going to work anyway, and then they're pregnant. So certainly don't tell people not to stop their pills because they're not going to work. That's kind of confusing. Don't not do this because it won't work. What am I supposed to do? Keep taking your pills. That's what you should do. Not the double negative. Always confusing. There are also drugs for seizure control that do not really have any impact at all. Important clinical impact. So you got to look it up. it's really a shame for someone to stop taking their contraception because of their confusion about a drug interaction. So be part of the solution, not part of the problem. You know, look it up, figure it out, so you give people the right advice on that. Okay, so these are some of the newer methods of contraception that have different delivery systems. Let's talk about these, just so you know something about them. This is the vaginal ring. It's called NuvaRing. There's only one vaginal ring in the United States. There probably will be more under development. And we also have a contraceptive patch. They have the same things in them as birth control pills, the same components. They have an estrogen part for the cycle control and the progestin part for contraception. So, you know, why do we do this if we have birth control pills? What's the point of this stuff? Why do this? They're not every day. So these are things that are extended release, so you don't have to do it every day, so it's a little bit easier for some people because it doesn't require the daily compliance for it to work. Okay, so the contraceptive patch, it's been around for a while now, about 10 years. People can put it on themselves. They can put it on in a number of places. It's like any medication patch. It's an adhesive, leaves a little bit of a sticky mark on the skin, but most people don't mind. You put it on once a week, and then you change it the next week. So it's a week on, and then you do that for how long do you think you do that? Just based on what you just learned about the birth control pills. How long do you think you stay on the patch? 3 weeks, and then how much off? 1 week. 3 weeks on, 1 week off, so they made it just like birth control pills. You could change that a little bit if you wanted to, but the pharmacy's probably only going to give you a pack at a time. So that's kind of what you got, is 3 weeks on and 1 week off. The efficacy is about the same as what we get from birth control pills. We thought maybe when these methods came out that we'd get fewer unintended pregnancy because it wasn't a daily method, but it turns out that it's probably about the same. I think it kind of, it almost makes more sense to me to do something once a day, once I've heard people how this gets to be a challenge, because then you have to remember it's once a week, like, oh, it's Tuesday, I have to change my patch, as opposed to I just take this every day. But some people do okay with it. You know, they figure out their patch change day, they know to change it, and then to go to the next patch. So this is the vaginal ring, the NuvaRing. Again, same stuff in it. It has an estrogen and a progestin. It's just put into this vehicle. So this thing, to give you a sense of size, it's about this big. It's completely flexible. It serves no function in terms of blocking anything or creating a barrier for sperm. It is purely a drug delivery system. So it's just placed in the vagina because the vagina is something that absorbs hormones, and you can easily place it there, but certainly you could put it anywhere else. It doesn't matter. It doesn't have anything to do with intercourse itself in preventing pregnancy. It is for most, so it's our same old thing, but this one, instead of being a 1 week like the patch, this one's a 3 weeks. So you wear it for 3, you take it out for 1, and then you put in the next ring. Wouldn't it be nice if we had a ring that we could just use for a long, long period of time? So that's under development, a progestin-only ring, which could be used for up to a year, which would be great, because then you could just have your method. One of the super cool new things that's out there that may actually happen is a little implant that has a remote control. That's a progestin-only implant that would go under your skin that you'd be able to use for decades, so that you could just turn it on when you need birth control, and then you say, I'm ready to get pregnant, and you turn it off. You get pregnant, you have a baby, and you turn it back on. That would be fantastic. I hope it's under development now, so hopefully something like that could actually occur, because that would be really, really great for a lot of people to be able to have that kind of long-term efficacy without a lot of maintenance. Occasionally, the vaginal ring comes out. People can certainly just put it back in. Its efficacy is about the same as birth control pills. Most people find it comfortable. You do not have to remove it for intercourse. All right, so now to the sort of progestin-only methods. All right, so remember I told you that estrogen does have a little bit of risks, but it's good for cycle control, so it's our trade with estrogen. These are methods that have only progestin in them. So this is the levonorgestrel IUS, intrauterine system. IUD is another way you can describe it. There's 2 of these now in the United States. One is a higher dose IUD. It's called Mirena. Some of you probably have one. The The other one is called Skyla, which is just the same thing. It's just a little bit smaller. Mirena works for 5 years. Skyla works for 3. So now we're talking about years as opposed to a month, right? A pack of pills at a time. So this is something that you get it, and then it's done. You can just keep it for as long as you need to use it, up to 3 years for the Skyla, up to 5 years for the Mirena, and they may work for even longer. We're getting new data showing that they probably work for longer. So this is our progestin-only method, so it has no risk of thrombosis with it. And since it has progestin in it, it's really good at making the endometrium thinner. So it's FDA approved for the treatment of heavy menstrual bleeding. So it works for contraception. It also works for heavy menstrual bleeding. So it's a very good, for a lot of people, it's really a fantastic method. This is the contraceptive implant. You see it there in the arm. It goes under the skin, subdermally, in the groove between the bicep and the tricep. And that is a 3-year as well, kind of like our lower dose IUD. And then this is the 3-month injectable, also a progestin only. It's called Depo-Provera. It's just given in the muscle, in the hip, or in the deltoid, and works for 3 months. All of these are extremely effective. Why do you think they're so effective? They have the same stuff in them as the other methods. There's no user error, right? So I don't even like the word, you're right about the concept, but I don't really like user error. It's like blaming people for, not being able to do something every single day for 25 years, Who can do that? If there's anyone in this room who has missed one day of hasn't missed one day of brushing their teeth, I'm sure you all exercise every single day, right? No, we don't work. None of us are perfect. So with these, once these things are going, you don't have to do anything. There's no maintenance. Okay, so once your IUD is put in or your implant is put in or you've gotten a shot, it's going to do what it needs to do and you don't have to keep thinking about it and dealing with it and going back to the pharmacy every month to get your refill. Depo-Provera is a relatively big dose of contraceptive progestin. Okay, it's a very, very powerful reducer of menstrual bleeding as well. Okay, so if you really want someone's period to go away, this is your best bet. 75% of women after 1 year of use will have no menstruation at all. So it's a terrific method for people with heavy menstrual bleeding, really works well. It's extremely effective, and as I said, there's gradually amenorrhea. It's unique in that it's the only contraceptive method we have that isn't completely, immediately reversible, okay? So Depo-Provera can take some time to wear off. So if someone says, I want to be pregnant in 6 months, I don't recommend this because you can have up to 18 months to have complete return of ovulation. Birth control pills, the patch, the ring, the IUD are all immediately reversible, meaning as soon as you stop them, you can get pregnant right away. It is certainly not the case, despite what is said online, but I'm sure you're learning that many of the things online are crap when it comes to medical advice. It is not the case that you need a washout of your birth control pills or it's going to take 6 months to get pregnant after you stop your birth control pills. If that were the case, why would it matter if you missed 2, for goodness sake, right? It doesn't take time for your birth control pills to wear off. They're metabolized completely in a day or 2 and completely out of your serum. The implant, also extremely high efficacy. Some people really like it because they know it's there. They can feel it. They know it's there. You can't see it unless you're looking for it. Most people don't have their arm, like this, looking at it, so you don't really notice it. It does require a trained person to put them in, but the training is straightforward, and after an hour or 2 of the didactic and learning, you can do it. And certainly well-suited to mid-level providers and providers in other areas of medicine who are not OBGYNs. You don't need to know how to do a good pelvic exam to put in an implant. It does have irregular bleeding, and why would it have irregular bleeding? Because it has no estrogen, right? It's the progestin only, and the progestin only methods can have irregular bleeding. You can feel it there, you know it's there, and some people like that. So this is it. Sometimes I have people say to me, it's super weird, I don't want to have an implant in my arm, and then they have some kind of tattoo on their neck or their face. Please. No, it's not. And I use anesthesia, If you're getting a neck tattoo, I don't think they give you anything. I think you just take it. Although it's funny when people get these huge tattoos and then they say, it didn't hurt. Right, it didn't hurt. You break. All right, so the levonorgestrel IUS, This is IUD again. It goes inside the uterus, and then amazingly, there is this reservoir right here, and the progestin, levonorgestrel, remember that from the beginning of the lecture, our old standby levonorgestrel comes out of this reservoir gradually over a period of 5 years, which to me is just absolutely amazing that occurs, but it does, and it works. So this is how it works. What does it do? It actually doesn't inhibit ovulation. So this is an exception to that statement I made about the progestin inhibiting ovulation. The way that this one works, because it's such a small amount of progestin that comes out of the IUD, it's not enough to feed back to the brain to inhibit ovulation. So the way that this one works is by thickening cervical mucus, so all of its effect is pretty much here. Okay? So if there's so much progestin in the uterus that the lining of the uterus gets thin, you don't bleed as much, and cervical mucus gets thicker, so sperm cannot get through the cervical mucus, and no pregnancy occurs. Where does fertilization occur? The fallopian tube, right? Does fertilization occur inside the uterus? No. What occurs in the uterus? Implantation, right? So there are occasionally, if there is a sperm that would get through here up into the tube, and maybe fertilization would occur, there probably is occasionally blockage of implantation, but that certainly is not an abortion. What's an abortion? If you're already pregnant and then we do something to end the pregnancy. So that would be something that happens after implantation. The IUD certainly does not cause abortion. That is another very important misconception that has been widely promoted through the media and through the interests of people who would rather not pay for contraception or have insurance pay for it, will claim that the IUD causes abortions. That is certainly not the case. We don't put IUDs in pregnant women to cause an abortion. That wouldn't make any sense. So endometrium is suppressed. Like I said, certainly bleeding is a lot better. The average woman, after 1 year of using this IUD, will bleed about half of wherever she started from. Okay, so bleeding is a lot less. And usually ovulation is not inhibited. Occasionally it is, but the main mechanism is thickening of cervical mucus. That was sort of the secondary mechanism for pills, but it's the primary mechanism for the hormonal IUD. And I like this image because it really shows you what's going on. Okay, so this is in a dish. This is sperm. This is semen. Okay, and then over here, this is cervical mucus. When Mirena is in place, the IUD is in place. And what do you notice about this? Very cellular. It's very viscous. Okay, and it's very thick. So it is a completely impermeable barrier to sperm. So that's how the IUD works. Sperm are here. Sperm never get past the cervix, not in the uterus, not into the tube. No fertilization occurs. So really largely a pre-fertilization effect. All right, I think we talked about this. Occasionally the IUD can come out. If it does, it's not harmful, but it won't work for birth control. If it comes out, about 1 woman in 30 will expel her IUD. There's commonly in the beginning when people are starting it, there is some spotting. Because you have your own ovulatory cycles, though, usually regular menstrual bleeding eventually occurs. And it does require someone who's been trained to put it in. Certainly, though, many nurse practitioners can do this and are very good at it. Our clinic across the street at 21 Audubon, all of our nurse practitioners and midwives are excellent IUD inserters. We also have a copper IUD. Let's see if I have a picture of it. No. So the copper IUD is a little bit different. It lasts for 10 years. It's been available longer. It's widely used around the world as are IUDs in general. Uptake in the U.S. is increasing. We were behind the curve on this for years. The copper IUD, the way that works is also it's spermicidal. The copper itself creates a spermicidal environment in the uterus. So once the sperm are through the uterus and into the uterine cavity, they don't make it up into the tube, and fertilization does not occur. So there's no hormones in the copper IUD. Some people are they like that part, the non-hormonal part. The part that isn't as appealing for some people, though, is that menstrual bleeding may increase with the copper IUD as opposed to decrease compared to what happens with Mirena. All right, so what's good about these long-acting reversible methods? Their failure rates are very low. So now I'm talking about the implant in your arm and the 2 IUDs that we have. The failure rates are very low. Once you get them, they're what I like to call forgettable. All right, once it's there, it's doing its thing, and you don't have to keep thinking about your birth control. They can be expensive up front to place, but the cost over time is really low because there's so little having to do maintenance or other visits related to them. And again, with the short-term methods, failure rates can be high because it's hard to do something every single day. And people often discontinue them for various reasons. Sometimes it's side effect, but sometimes it's just because they can't get another prescription from their doctor. And if you think about it, if you took them for the average of 25 years, you'd have to take 9,125 birth control pills in order not to get pregnant. That's a lot to do. Okay, so what is emergency contraception? Also in the news, often in the news. We have two of them. This is the one we've had the longer. It's called Plan B. Plan B is just levonorgestrel. So it's that contraceptive progestin I told you about in the beginning. So since it's a contraceptive progestin, what do you think it does? How does it work? Clue. What did the progestins do in the beginning? What did they do to the menstrual? They inhibited the LH surge and they inhibit ovulation. Okay, so that's how they work. So emergency contraception, progestin, is just levonorgestrel. It's just the same old progestin we have in birth control pills. It's at a slightly higher dose. As long as you take it in advance of ovulation, enough of in advance of ovulation, this is an ovary and this is a dominant follicle. You can prevent ovulation from occurring. So do you think it can cause an abortion? No, it certainly can't. If a woman took 50 of these, what would happen? She'd just be full. That's it. You can't hurt yourself taking a bunch of contraceptive progestins, and you certainly can't cause an abortion. As a matter of fact, we give progesterone to pregnant women to prevent miscarriage. So did you learn about how treating premature labor, they give people progesterone shots to prevent premature labor? So progesterone certainly does not cause abortion, all right? So these certainly don't cause abortion. Another common misconception. Ella is the new contraceptive, emergency contraceptive. Ella is a selective progesterone receptor modulator. It has a more complicated mechanism, but it works the same way. The reason we're using this first line is because it works a little bit better when intercourse is a little more distant. Plan B really only works for about the first 24, 48, a little bit after 48 hours, but by then, usually it's too late. Ella will work for a full 5 days after ovulation occurs, or after unprotected sex has occurred. And the reason is it can delay ovulation for up to 5 days. Once ovulation has occurred, these do nothing. Okay? What they really do is prevent ovulation from occurring. There may be some really distant secondary mechanisms, but they're not really what's going on. You really have to take them before ovulation occurs. How long does sperm live in the genital tract? How long can it hang around and be viable?
3 days.
What'd you say? About 5, okay? So if you have sex on Friday night and it's unprotected and there's sperm around and ovulation occurs on Sunday, you can certainly get pregnant, right? So the unprotected sex that occurred on Friday night, if followed by emergency contraception, the ovulation on Sunday will not occur and pregnancy will not occur, right? So we're trying to prevent ovulation from occurring so that pregnancy does not occur. All right, there's also lactational amenorrhea. You have a lecture on lactation? Do they have that this year, breastfeeding? So how does this work? This is another one of our feedback loops. So breastfeeding causes, during breastfeeding, prolactin is very high, and that inhibits ovulation. It is not a commonly used method, obviously, because most people are not lactating. And the problem with it is that unless there's almost continuous breastfeeding, there's no supplementation. If breastfeeding isn't happening all the time, there isn't complete inhibition of ovulation. So you really have to have the baby with the mother all the time. So for women who need to be away from their baby for working or whatever they have to do, this is a tough method to use. But it is certainly used in other parts of the world where women spend all their time with their newborns. So these are other contraceptives that are available. I'm sure many of you are familiar with the condom. This is the copper IUD. These are other things. The diaphragm, largely these things have fallen out of favor, largely because they don't work very well. Okay, so the failure rates are a lot higher with these condoms. The failure rates are about a typical couple that relies on condoms as their only method. About 10% of them will be pregnant in a year. Compare that to hormonal contraceptives where it's 1% or less, as long as